Good afternoon, everyone, and a warm welcome to the latest webinar from the team here at Nolex. Special thanks to Keith Edwards and Tim Sanford for making today happen. I'm Alan Chadwick, Head of Research at the team at Nolex. Our team hosts and disseminate healthcare information and education via all year-round activity, including our conferences and, of course, as you see, our webinars. Before we get the webinar underway, a couple of short items of housekeeping messages. We ask you don't share screen grabs of the slides during today on social media. There will be PDF versions of this made available to you through our team by Friday, by tomorrow. So look out for your emails for access to those. During the webinar, you will be able to ask at any time questions of our presenters, for them to pick up the questions at the end of the key presentation, if you like. So very simple process. All you have to do is to go in the chat box on the right-hand side of your screen, write that in, and we'll start running through those when we've completed the main sort of presentation element, and get through as many as we can. Any that aren't covered, we'll get Keith and Tim to cover those personally by email with you and the wider audience as well. Today's session, of course, will be recorded and it'll be available to view on demand from tomorrow. So look out for information on that. Everything good to go, so let's get started. It's my great pleasure to welcome our speakers, Keith Edwards and Tim Sanford.
Good afternoon, everyone. How are you?
Good afternoon.
I'll start. My name's Tim Sanford. I'm one of the directors of CIBUSHEALTH, and I won't speak for terribly long because actually Keith has much more important things to say. But fundamentally, the most important thing about today's session is that it's as much an opportunity for you to ask us questions and discuss things, because whilst we have developed something, we believe that this is not our system. It's actually, because it's designed for the healthcare sector, it's as much your system as it is ours. So as much feedback and as much input as you can give us helps us ensure that what we develop actually works fully and properly for you. So to crack on, a little bit of background as to why we developed CIBUSHEALTH and built a company called CIBUSHEALTH. We had been working, Keith and I have been working together for a long time, but we've been working in and around the food data space for 7 or 8 years. And, you know, I had a number of relatives who had finished up in hospital. We all had friends who finished up in hospital. And what we found was that catering wasn't able to meet their needs. So even things like a simple allergy in some hospitals became problematic. So we started speaking to people in the NHS and healthcare in general to understand why hospital food wasn't delivering the benefits that patients need to ensure that they recover. And what we find out is all things that I suspect are no surprise to you. Budgets for patient food have been either lagging behind or in some cases actively cut over the years. And as a result, food quality is down, nutritional value is down, and wastage is excessive. Food fundamentally appears to be a low priority in the overall complexity of hospital operations and healthcare, a sort of Cinderella factor, if you want. So as a result, hospital food is a problem, and there are a growing number of complaints from patients and others, to the point that there was that 2020 NHS hospital food review. And we also found out when we were looking at this from a systems point perspective, that the systems that are currently available to you to help manage this were not really designed for the healthcare sector. They tended to come at it either from a procurement and supply chain management perspective or from a hospitality meal ordering perspective. So they didn't really incorporate or don't really incorporate everything that you need. Now, why do we believe hospital food is vital? Well, again, you know more about this than we do, but the old saying that an apple a day keeps the doctor away has, in our view, never been more apt. Nutritionists, dietitians, and experts of all kinds have long known and long said that good quality nutrition and good quality food is absolutely essential to ensuring that patients recover, or if they're in hospital for the long term or care for the long term, that their health and well-being are maintained. From a personal perspective and experience, we found that the pressure on NHS budgets is extraordinary, and has left patient food as one of the paupers of NHS funding settlements. And the other thing that we couldn't ignore with our experience in other parts of food data is just the increasingly complex dietary needs and preferences of the populations, which means you need much, much more information from far deeper down inside the supply chain to be able to look after patients, from patient to procurement. And finally, with the new rules and regulations coming into place, data has become the most important tool to enable managers to make the decisions that you're having to make, and make them better, because you've actually been given the data to be able to do that. And I know from speaking to professionals that data is still a huge problem in terms of what you have. So when we set out to develop CIBUSHEALTH and the CIBUSTrace family of products, we looked at it from a purely healthcare perspective. So this, that Keith will talk you through in a little while, is built purely for the healthcare sector. We also recognise that because data is the critical factor in this, both from enabling patients to make better informed decisions about the food that they're eating, and clinicians to support that, and procurement to be able to buy the food that the hospital needs at the quality it needs, data is critical. You can't do this without volumes of data. So we built this around really accurate food data, as farm to fork as we can get it. And in our view, only by taking a really multi-dimensional approach and thinking about this from procurement to patient is the only way that you can solve the problem to deliver better patient outcomes and care, ensure that every patient is served food that is appropriate and safe for them, reduce workload on staff, and wherever possible, eliminate complexity, which is the bane of everything, reduce waste, help reduce costs and errors by having an end-to-end system, and finally provide the data that managers need to both satisfy the new regulations and make decisions that they do not have enough information to make today. So starting with our first iteration, which is the patient meal ordering and management platform, CIBUSHEALTH is now available. And we are actively looking for more people to talk to, more conversations to have, to make sure that what we are developing absolutely fits your requirements as healthcare professionals. So that's enough from me. And I'll now hand over to Keith, who will talk you through CIBUSHEALTH in a bit more detail. Thank you very much.
Hi, everyone. Thank you for your time today. What I'm going to do is I'm not going to give you a full demo of the system. I'm going to talk about our approach, some of the areas that we're covering, and also show you some screenshots of the product itself to give you an indication, flavour of how serious and how detailed that we've already gone into this, particularly at the minimum viable product stage. As Tim said, we are looking for more people to work with and pilot with this system, and 2025 is a development year for us, but we're already confident the system we have is far ahead of anybody else in the marketplace, critically because we've designed this, as Tim has already said, specifically for healthcare. We haven't come about this from hospitality or any other sector. And the driver is transparency, complete food transparency, farm to fork, including production and all of the details. The system we're building also updates automatically, which saves managers time, particularly in busy environment where the data itself, we're using verified data, which I'll talk more about as we go on. And we're also providing much more detail around that information that we give. It's about educating patients as well. So supporting patients on journeys around obesity, even when they're using the diet drugs, if they're coming off of those, we know the issues around those, we know the potential problems in the future, and actually having systems which support them on this journey where healthcare professionals can work with them in hospital as outpatients or wherever they're situated is vital. One of the things that we wanted to do is connect everything up, and that's really important to us. So what we've done with the system is we're going to be working with the APIs from the start and connecting them to all parts of the healthcare environment. So our ambition is to have patient nutritional records detailed that are connected to their medical records, because I think we all recognise that food is a critical part of recovery. It's also more and more in the news because of the costs to the NHS. Malnutrition, for example, as you all know, cost last year more than £20 billion. Food waste, I think it's in excess of 200 million. So moving on from that, what we're doing is the system is also fully compliant. So we're working to complete DTAC, building the APIs, and also following all the other compliance regulations that the NHS have. We want to make this as easy and as foolproof as possible, and we've invested an awful lot of money into doing that as well. Ongoing, what we're intending to do is to collect more information for clinicians, nutritionists, and food managers on behaviours, eating habits, waste and nutrition of individual patients, wards, hospitals, sites, broken down in any which way you need to see that report. And yes, so you're aware, everything will output for Eric as well, the reporting annually. But not only that, we make all this information available on a daily basis if you wanted it. So again, we know that this will save time and money in administration throughout the year. The other thing that we're going to be doing, particularly around waste, is, I think as you're aware, a number of platforms offer the ability to record whether there's been plate waste or not. There are some systems in the US which record the weight of the plate, which doesn't really give you much information. What we're working on is building an AI model which will support using imagery to identify ingredients on the plate that have been left and identify the weight of those ingredients. So, for example, if you've got a patient that's been ordering chips and never eaten them, you can identify this early enough and actually address it before that waste cost becomes unbearable by the individual patient. So there's some important developments we're doing here, which is going to make cost reduction easier, more viable, and actually reduce work for the individual facilities managers, food managers, wards, and actually the management of the hospital and trusts. What we're also going to be doing is recording food miles, carbon impact, and much, much more information around that food itself. Obviously, all allergens are covered. Now, we cover the legislated allergens. We cover lifestyle, religious, but also you can add allergens, and we will be increasing the amount of allergen information on ingredients and dishes on the platform, which will automatically be available whenever you move anything into a menu or create a new menu. So again, saving workload and increasing accuracy and safety. The other thing that we've with the platform being very structured around healthcare, is conditions which are affected by food, not just allergens or lifestyle, actual medical conditions, that can be tagged on a dish or ingredient and therefore removed from that patient on a menu whenever they look at it. So they can't order it. Again, another layer of safety. And we will look to our pilot partners to increase that information and to make it a lot safer. Where we differ is that when a patient sees a menu, once we have that information on their allergens, lifestyle, religious needs, and also the conditions, they can't see the food they can't eat. That also applies for anything they buy externally as well. So if they're ordering a pizza from outside the hospital and their fat intake is being monitored by nutritionalists, the system will block it and it will warn the patient they shouldn't be eating these foods. But if they buy something externally, they can pay for it as well through the system. So again, all these things are coming through 2025. The MVP that we have now and that we're piloting with will have a lot of this ready to go live. What we're also going to be doing with the system is uploading the recipes, 3,500 dishes that are currently in the NHS database, plus dishes from books like the Healthcare Chef's Knowledge Book. And we want to increase that database on the system, including providing the ability for chefs in various trusts to share new dishes, cost-saving dishes across the NHS. So collaborative work at kitchen level becomes possible, something which wasn't possible before. And again, this is all about making life easier when creating menus. As I said before, with the data, we're using a national database or an international database, which is currently used by the major supermarkets. That will go live towards the end of 2025. Supplier data, we will be working with the suppliers to add their information into the databases. So again, you don't have to go looking for this information. We make it easy for you. We want support in doing that when talking to the suppliers because it's a collaborative operation and the food industry is very difficult about this. We know why. There's a lot of things they don't want to talk about, but if you want transparency, particularly in healthcare food, we've got to go down that route and we've got to force this to change and force it to happen. So again, everything that we're doing is open and transparent, even down to where supply chains fail and you're creating a meal using supermarket food. That data will already be on the system and we allow you to create emergency menus and store them. So if something happens to the supply chain, which has happened in the last 12 months to many trusts, you can switch to a supermarket menu, base menu, where you're buying it in locally. That information is already on the system. So again, there's no interruption to the nutritional information that the patients see, managing their diet and nutrition properly. It's all there. And again, makes life easier for you guys. Okay, so what I'm going to do now, I'm going to switch to, as long as the technology is working, a couple of screenshots of the system and some notes, and I'll talk through what you're looking at there so you can see a little bit about what we're doing and you know that the system is real. If anyone wants a demo of the system, please contact us and I'll be happy to meet with you as soon as possible and run through it and show you it working. So hopefully this will work well enough. Bear with me a moment and I'll switch the screen on. Okay. Okay. I'm assuming everybody can see this now. So the first screen that you're seeing is our patient record. So when you come into the system, everybody sees a summary page of everything that's going on at ward. Facilities managers will be able to see ward, hospital, and multiple sites all in one screen. So they can see what's going on at every different level in detail. So at ward level, this is typically a ward screen that you're seeing. The ward managers or nurses or orderlies will be able to see this information about the patients. So on screen, we are seeing the bed number they're in, malnutrition information. Now, currently we're using BMI for this because it's a demo. I'm aware that people want to move away from, or the NHS wants to move away from using BMI and using the waist to chest ratios or other measurements, all of which we're ready to upload and actually work with. But what this shows you is using the malnutrition information of the patient, we can actually monitor them on this summary screen. This also includes hydration. And with the hydration, we're assuming the data we're using here is that the patient is using or has to consume 2 litres of liquid a day. So it raises a warning. So again, all of this information can be changed, the algorithms can be changed as you tell us and work with us. Net calories, and this is where it gets interesting, particularly when you're dealing with patients that you're working with, particularly around nutrition, with food issues. These are net calories, and we will calculate this using the waste data. So where we're capturing plate waste, and as the AI model grows and understands more and more through the coming year, we will be able to provide net calorie and net nutritional information from a patient on a daily or by meal basis. This also means that you get a more accurate, and the patient gets a more accurate data information about what they're doing. Here we're showing whether a patient's secluded or not. Nil by mouth is on here as well. Now, what we're doing with nil by mouth, and particularly we've been asked about this from our US partners, is we can actually, with nil by mouth, we can actually date this. So you can set a date that this patient goes nil by mouth, and you can set a date where that stops as well. So again, that makes it a bit more foolproof and a bit easier to use. Obviously, sex, allergens, basic information there, number of daily orders made. Okay. So all of this information, all of this is gathered and held within a reporting system within CIBUSHEALTH, and again, can be outputted to Eric at any time. What we want to do is, as we grow with the APIs and we link this to a patient's medical records, and certainly where we make these connections across other environments, where you're working with care homes, GP hubs, this information with a patient can be visible from anywhere. So if you're dealing with an outpatient, if you are monitoring a patient that's in a care home, and you're monitoring malnutrition and hydration, net calories are consumed, as long as the care home's putting information in, you can see from the hospital point of view what's going on with a particular patient. So again, much more opportunity to reduce costs, reduce bed blocking, because you can see, particularly if there's a condition arising which is being triggered by healthy food intake issues, you can see it. Okay. Typical ordering page that we're showing here. Again, this is the early version. It is a particularly long-winded way of approaching these things, but we need to make it as simple as possible, as quick as possible. So there's a lot more information that may be on here now that might not be there in the future, depending on what your needs are. One of the other things that we're doing, which is really important, is against each food, we are showing calories, sugar, fat, salt, fiber, carbs, protein, liquids, but also particularly around high fat, sugar and salt, we show warning signs. So if a patient is ordering food from the menu that is high in sugar, fat and salt, if they order too much, it will be triggered here and highlighted as, well, you've ordered too much food with too high salt, so that needs to be changed. So anybody at ward can see this and address it with the patient. The patient is also fully aware of what's going on based on their nutritional needs. And again, another level of safety, particularly around the current conversations on high fat, salt and sugar. What we have here is breakfast, dinner, lunch, meals, finger food, purees, drinks, anything that's necessary for a patient in any type of ward or environment. We also include occupational therapy. So where occupational therapy, particularly on mental health units, is happening, you can switch to, say for lunch, if the patient is being taken off a ward, to work on occupational therapy around food, cooking their own meals. Those meals can be uploaded. That information will be added to their daily intake, including waste. And so everything that happens around food, as you can see, we're capturing it. Going on from there, I think, yeah, all menus that we do can be created in advance, given a go live date, and automatically switch. Again, which makes food managers' lives a lot easier as far as managing the information and actually wards and entire trusts. This is another slide of what the final information looks like. The facilities teams will receive currently on the MVP a CSV file of every order made on the wards. That can be then downloaded and uploaded into the ordering system. And again, what we intend to do, working with the APIs, is to automate this process. So from ward, the facilities team can check an order through by ward to make sure every patient's ordered. Hopefully the ward is aware and seeing the warning signs if a patient's been missed. That then can be uploaded straight into the ordering system or passed through to the ordering or distribution centres, however your trust and hospital particularly works. And again, all the information is held here visually and text. We will be changing languages as we go on. So certainly with patient ordering, everything is visually based. We will add audio to ordering for those with poor or blindness, poor eyesight or blindness, and multiple languages. So again, making it accessible across the board and easy to work with all the way through. So that is a really quick overview of what we are working to achieve. And I hope you can see that we've already gone quite a long way in comparison to our competitors because we are focused on healthcare and healthcare only. And the only other thing I will add to the conversation is, if this is of interest, come and have a chat to us and I'll show you more. And anyone that's interested or in the process of looking at food ordering systems, please contact us. The more people we have on the pilot, the quicker this develops and grows and becomes something valuable to not only food operations, but clinical as well. I'll hand back to Tim.
Thanks, Keith. As Keith said, we are actively looking for partners to pilot with, but fundamentally, we're also looking for people to talk to who can tell us where we've gone wrong and what we've got right. Because again, as I said right at the beginning, this is your system, and we just happen to be making it, but we're making it for you. So Alan, I'm going to hand back to you because I can see that there's a fair number of questions have appeared in the chat, which is great. So we'd like to crack on and start answering those if we can.
Delighted to. If it's okay with everyone in the room, I'll very much start from the top, way back from the beginning. Tim Radcliffe from NHS England makes the point that the food review for hospital food was not about complaints, more about patient safety. If either of you two wanted to chip in on that or take it into that. He also mentions, yeah, do you want to chip in on that comment?
Yeah, so no, I agree. I mean, we notice complaints because, you know, we're at that end of the universe. Absolutely, having read the review, and it's one of our Bibles, as it were. It absolutely is about safety and quality, and a lot of what we've built in is specifically to deal with that. So yeah, no, it's a point well made.
I'll jump in with Lenny Bond from Hertfordshire Community NHS. Was this information that you've brought together gained from acute hospitals, or did you just speak to a variety, such as mental health?
So we've spoken to mental health, we've spoken to acute, we've spoken to US private healthcare, we've spoken to long-term care facilities. So it's as much as we are able to, it's a rounded view of what we believe healthcare needs and what healthcare has told us it needs. As Keith has said on a number of occasions, it's an early iteration, the first iteration of the product. We're still learning and still listening. So if there are things we've missed, we'd love to know what they are.
Good. Tim Radcliffe, NHS England. Observation, if you'd like to chip in. No such thing as a food mile. There is no agreed definition.
Totally agree. The whole concept, people talk about food miles. We have, because there is no agreement on this, and the whole carbon cost of food and carbon cost of making food is such a contentious area. And there is so much mis and disinformation around it that, like most people, we have not yet arrived at a single best way of doing it. There are a number of calculations we could impose, but no, completely agree on food miles. It's one of those phrases that gets used far too much and with very little substance underpinning it. So again, good point, well made.
Yeah, well, I mean, the only thing I'd chip into that is that what I was trying to show is that we want to capture and work with all of the information and all of the needs, particularly as policy changes, and that we can do that. But yeah, I completely agree with Tim. I agree with the comments as well.
I'll bring in a question here from Serena. And Serena, I hope I don't do your surname too much of the disservice. I think it's Escavadere, and I do apologise. What is the cost implication for the equipment that could identify the leftover products from the patients?
A mobile phone.
Yeah, that's it.
Basically, because it'll sit. Sorry to interrupt. Talk over you. It will sit within the app. And anyone who has permission to log in and use the app, when they're picking up a meal at the end, it'll be a simple question of taking a photograph of the plate, and the AI bit, which is the only bit of AI we're going to be using in the short term, will identify what's been left, and that's much. I mean, a lot of what we've seen is just about weighing the waste and turning around and saying, we've got 105 kilos of waste left after lunch, but it doesn't tell you what's been left. The AI model that we're working on is designed to identify that somebody's left Brussels sprouts because they were on the dish to be served, and they're the bit that's left. So in summary, a mobile phone.
Okay.
Yeah, I mean, just to add, the models that we're going to be using, they're already being tested and being used. So we're not reinventing the wheel with this, but yeah, all the equipment that we use and how we've built this and structured this is to be as simple, cost-effective, and using existing technology that you already have. Okay, Alan.
Question from Tim Radcliffe from NHS England. Tim is referencing three other brands that are out there in the technology space.
Yep.
How is your concept different to Saffron, to ACS, and to Symbiotics?
I'll tell you what, rather than trying to answer that very pertinent question on a call, why don't we put that down in writing, and that way you can share it around everyone, and it'll be our considered view. Because I'm not a believer in bashing competitors or other platforms. We developed this just by listening to the market and listening to professionals like yourselves, and I think it's probably better if we answer that in writing, if that's okay.
Okay, we'll move on from there. Next here, again, I think it's from Tim. Oh yeah, Tim asked, what carbon factor information is provided, and what data do you use?
It's actually, as we've been talking about the food miles thing, the quality of data available on the carbon footprint of food is actually very complex. It's partly complex because big food manufacturers have a habit of not being as honest as they should be, particularly if it's imported food. So we have to make estimates. So, if something is imported from Spain, we can add some, and we know how it's coming, we can add a degree of a carbon factor. If it's not organically farmed, there are other carbon factors that can be added in, the cost of nitrogen fixers and so forth, and the carbon impact of those. But it's still an extremely inexact science. And within reason, we do what we can, but we are limited with the data that is made available to us by particularly the large producers. Small producers is really easy because you can just go and ask them how they do things, and they'll tell you and provide you with the paperwork. So the bigger the supplier, the more difficult and more opaque this is. The smaller the supplier, the more the simpler and more transparent it is, if that makes sense.
Okay, next one, yeah. Tim Ratcliffe, NHS England. His question is, when the supply chain to hospitals, I suppose, fail to the extent that supermarket food has been required in large amounts.
Mm-hmm.
Oh, is that a when has?
When is it? Yeah, you referenced.
Oh yeah, there are. We know of at least one hospital that was at the stage where they couldn't get bread, so from their suppliers, so they were having to buy from supermarkets. And we know that from time to time that is not an isolated incident.
Yeah, we don't want to reference the hospitals or trusts, but they were organisations that we were working with and talking to at the time around the development of the product. So that was the information that we were given and told about, because it also interrupted some of the information that we were trying to capture.
I'll bring in two connected questions from Suzanne Morris.
Yep.
How will this be recorded in patients' health records for further evidence, i.e. court case? But also she mentions, you say, many level of staff can see the platform. The question is, this seems to go against patients' privacy policy.
No, it's so that we're intending to use the CHI number because it's the most appropriate one to use. It also means that when a patient moves bed, it can do that. How the record is stored and where the record is stored will be down to agreements we put in place with each individual trust, as it may be that some trusts will turn around and ask us to store that information. Other trusts will want to have it downloaded and stored somewhere where they want to, or on a cloud space that they want to. Individual members of staff will have logins, and logins are all permissions based. So if you're the facilities manager, it doesn't mean you can just log in and see the entire food record of an individual if you do not have permission to do that. Whereas if you're that particular individual's dietitian, then clearly you would be able to. Ward staff have a different set of permissions because they're predominantly focused on making sure that the patient has ordered their lunch and that the lunch fits in with their nutritional profile. So it's permissions based and role profile based, if that makes sense. But we are very aware of that.
Yeah, and the app actually records all logins and all activity.
Okay, yeah. Follow-up question from Tim Radcliffe from NHS England. Obviously, you referred earlier to the ERIC, which obviously is the estate's recording system for hospitals. Why would calories be required in ERIC?
I'm not suggesting it would be, but the information is there. So we already know what the information is required by ERIC, and the information that we capture will be there. If at some point they wanted to expand on it or to use that information that's captured, it can be extracted anonymously and made available to the hospital, hospital managers, or further than that if they wanted to. It's not our decision where this information goes or what is reported. It's the reporting system can be set up by individuals within the trust to work for them.
Okay, question from Suzanne Morris. How do you link to medical records? In her words, most are not electronic.
So this is one of those weird ones where most, as far as we can see, most medical records are a hybrid of physical paper records and some digital. And the answer is that by using the CHI number, which is our preferred route, we'll be able to or if somebody looks up the patient's CHI number when they have access to our system, they will be able to see a record. But it's has as much of a limitation as every other system in a kind of hybrid data environment that the UK health record is, and that is a very Scottish view, because that's where I've had a lot of my conversations up here.
Question from Serena, talking about systems linking with each other. How can a connection be done with medical records, considering every setting uses a different system for medical records, and not all system can accept linking another system? I suppose it's a follow-up to what you've just been put there, but
and that's to do with the spine. So the spine enables data sharing across the NHS, and that's the API set that Keith refers to. So we are designed to back into the spine and be able to pass that data. If somebody isn't using the spine and they want to take data, so long as we can collectively be satisfied that the correct security levels will be maintained, then we can push the data out in a different format.
Question from Suzanne Morris. Many relatives, especially for the very young or elderly, will bring food in for the patient from home. How will this be captured?
It can be added manually. I mean, the food data set that we have covers pretty much every known large manufacturer. So if somebody brings in, I don't know, a bag of a tube even of McVitie's digestive biscuits, the whoever's using the app, it could be the patient or the patient's relative or a member of staff, can scan the QR code and it will add that food probably, in the case of digestive biscuits, probably as a snack. If, on the other hand, they bring in a meal to do that, then that can be added as as a meal. So mince and potatoes, because those are standard recipes, so they can be added, and an approximation of the nutritional profile will be added in. It can be marked as externally sourced.
Okay. Just a useful note in on the ERIC conversation we had just a few moments ago. Max Kindred from NHS England has actually put live there. Is anyone interested in the national position on ERIC, net zero food in data? As the owner, it's interesting to hear from Max. I'm happy to have a quick chat with them. So Max is there.
Great.
This is interesting. Edward Stephen Hall, how does the patient choose the meals, with what equipment?
So two ways they can do it. If they have been allowed to, they can log into the app, and all they will see is themselves. So it's an individual login if that's if the trust is going to allow that. Alternatively, if the whoever's taking the meal orders can show them or share a tablet or a mobile phone screen. And again, the assumption is that some of this will be NHS equipment, and some of it will be personal equipment. Then effectively that individual can look at their profile and order their meals. It's Keith, if you ask for a demo, Keith will show you this, but it's remarkably simple and very easy from a ward management perspective.
Questions here from Tim Radcliffe from NHS England. First of all, he asked, what frameworks are you chaps on?
Not quite sure what he means by frameworks. If those are procurement frameworks, the answer is none yet. If he's asking something else, again, I probably just want to take that offline.
Yeah, if he's talking about the actual platform, it's WebOS. So it works on tablets, mobile phones, laptops, anything.
To ask how this waste technology is different from LeanPath, LEANEATH.
I'm not 100%. Cool.
Again, probably better to take this offline and answer it in writing, so that can be shared around.
Follow up from Tim as well. We haven't got accurate data from food waste in portions or weight in the NHS yet. So moving to individual items is, in terms of words, light years away. Will your system measure for mandatory waste streams?
As long as we know what the mandatory waste streams are, yes. And the point about managing this on an individual basis is it's the only way that we can support clinicians in identifying where patients are not eating what they should be eating, and secondly, in order to get the volume data that the NHS is looking for, you have to measure on an individual basis, in our view. Otherwise, you're kind of just weighing, a big bag of food at the end of a service.
Okay. Are you two guys able to, just a question from me, I suppose, are you able to share with the audience where you currently are in terms of relationships with the NHS and what you're behind the scenes developing and piloting, obviously without naming names because of confidentiality, but what stage are you at?
I think we'd characterize this as we have been working with one particular trust very closely, who have helped us identify all sorts of really interesting things and design interfaces and so forth. They were the ones that that particular trust was the one that showed us that everything has to be pictorial as well as in writing. So we're very close to them. They're going through their approval process, so I'm not going to say anything more beyond that. We also have some very close relationships with US healthcare providers who are moving very fast. So a lot of what they need is a little bit further ahead than the NHS, because they've been thinking about it longer, and they've also got insurance companies demanding reductions in waste because it comes as part of their cost base. So that's a very important part of it. And we also have extremely close relationships in the supply chain that are helping us to shape the way that we work with the supply chain to get the data that we need to make the data that procurement entrusts users to make decisions.
Follow-up question here from Tim Radcliffe, NHS England. Who will input the nutrition and hydration data into the system? Question mark. It is supposed to be done now with the food charts, and to quote Timothy, is not done fully now, exclamation mark.
Yeah, so I don't disagree with him. Again, part of what we're trying to do is make this as simple as possible. So the first iteration relies on a combination of the ward staff and also individual patients being able to do it themselves. The reality is it won't be perfect at the beginning because, as Tim quite rightly points out, it's not being done properly just now. And it's only by observing and learning from that, and watching, that we're going to be able to get this to the position that the NHS wants it to be at. It's designed in, and it will be iterated until it gets to the point where it works as tightly and as fully as the NHS wants.
Message from Suzanne Morris. She writes, your narrative was in English. Is it available in other languages? I'm surmising, talking about the slides and content. I hope I'm doing you justice there, Suzanne, but do you have a multilingual sort of offering for your narrative, as it's put?
Well, yeah, we could get that. We could. I mean, it's only been done in English just now, but we're quite happy to do. Is that another? Is that because I just saw a message up?
Suzanne's put, not the platform for patients to order and stuff to fill. Oh, she's talking about the.
Yeah.
Do you see that there?
Yeah, it will be. The intention is to add multiple languages against the ordering in both text and audio. So that's something that we're going to be building into it. Yeah.
It's and that's now really quite easy to do. So it shouldn't take us desperately long to get that done.
We'll seem to have a thumbs up from Suzanne on that, so that's good. Edward Stephen Hall writes, patients choosing a menu from an iPad takes a lot longer than choosing from a printer menu to award food service assistant. This system is likely to increase the menu ordering times. Well,
what I would say to that is, I don't disagree that when you give somebody an iPad, it will take them slightly longer to scroll through and decide what they want to have. There's going to be no argument about that. However, what we do know from the hospital that we've been working with is that once the order has been taken on a paper system, by ticking boxes or whatever, then getting that data down to through the process to get it delivered on time to the right patient in the right bed. There's quite a lot of workload involved in that, and the balance between the additional time taken at ward level it means that there's time saved across the rest of the operation. So it's a bit of a balance. The other thing that we're seeing a lot of positive feedback on is the notion that patients will be able to have their own login to the system and be able to order their own food. That's considered to be a strong positive because that will mean far less time from ward staff being able to manage that. But most importantly, in terms of tracking that, if somebody does order their own food through the app, then that's noted so that there is no need for then a member of ward staff to go and ask them. So it's a bit of a moving picture, but the point is well made. Giving someone an iPad does take more time at the front end, but it should save lots and lots of time at the back end.
Absolutely, because without speaking for NHS England, because I'm not qualified, but the electronic meal ordering system is very much there as this is the way we've got to sort of move it. I'll bring in Serena's asking how we can get in touch with you to understand in more details the system. So clearly, Serena, Keith, and Tim will clearly be delighted to connect with you on that.
Yep.
Yeah, absolutely.
Very
I mean,
happy to.
Alan, if you pass on the information, we can book a call or a Teams call. I can demo the system and answer any questions. And as far as the next message is concerned, just to preempt, I've just seen that. Yeah, the way the system, we're thinking about adding the ability to print from the menus. So you can print a menu from the system on ward or in the facilities department. But then again, there is a manual process to put it back into the system once the patient's ordered. So that's something we need to work with you. We can't answer those questions from where we stand now.
Yeah, because Suzanne just chipped in on the front end. It could be nursing staff helping the patients to complete, especially the staff who do the menu have left the ward. So it's there for you to sort of feed through on that.
Yeah, I mean, these questions are great because they're, it's further learning, further information and insight from us, or for us even, all of this gets taken on board and listened to because, like I said at the beginning, this whilst we're writing the software and we provide it, it's your system. It's designed specifically for healthcare, so it has to work for you, and all this insight is absolutely fantastic. It's worth its weight.
Yeah, absolutely.
Well, we're nearly at 2:00 now, so I suppose I should ask the most important question of the afternoon to Tim and Keith and everybody is, what's for lunch?
If it's anything like my local hospital, it'll be a Greg's steak bake.
Oh. Well, yes, we're largely an English audience today, so I hope nobody is offended by that. Obviously, other steak bakes are available. Yeah, absolutely.
Me, I have no idea. I haven't thought about that.
Well, listen, I'm delighted that we've come through very positively and open up the conversation there. Everybody that has contributed to today's questions and answers, terrific to hear that. Thank you to Tim and to Keith. Just a reminder for everybody that overnight we will get all this put it together in a recorded format. That will be communicated to you there. The slides and everything else will be pulled together. And it'll be available video on demand from the morning. And also, I think my colleagues will make sure that CPD attendance will come through documentation on that after the weekend. But in the meantime, thank you, Tim, thank you, Keith, and thank you everybody for participating in today's webinar. Really enjoyed it, and see you all soon.
Thank you, everybody.
Yeah, thank you, everybody. It's been really good fun. Thanks. Bye.
Thank you.
Bye-bye now.
Bye.